I'm going to go ahead and place the towel here, and then I'm going to come arm over arm, and I'm basically just going to lean back, and I'm also distracted. And so there's a little bit of a vector that's going up. And so from this position, I can just do some mobilization, so non-thrust, just using her elbows, or I could have her take a deep breath in, long breath out. Good. And I can use a force vector that's posterior and a little bit superior.
You know, Amy, that non-thrust technique, I think, looks a lot like traction.
Yeah, I agree with that.
You know, distraction and traction are pretty synonymous in my language, at least. And
Yeah.
I think for the individual that has some of that pain that radiates to the anterior side of the chest, I'll use that as a manual therapy treatment technique, but also a way to assess reasoning as to whether or not that patient would benefit from a thrust.
Yeah.
If symptoms abolish during the non-thrust position, that's usually a clue to me to then progress to a thrust.
Yeah, I agree. I think sometimes as providers, we're too quick to kind of get in here and set something up and do it, but there's a lot of data that comes in as our hands are in there and as we're setting up the technique. We'll talk more about pre-manipulative hold in the cervical region, but basically you're describing a pre-manipulative hold, which is just putting the patient in the position, assessing what happens. And a lot of times I do that anyway, just to make sure that it's safe to proceed, you know, with that particular intervention. Are there ways that you perform this, you know, differently than how you saw me doing this in the video?
Like we commented in the lumbar spine, I've just got a lot more length to me.
Yeah.
So for me, if I place a towel between myself and the patient, I find that that can change my relationship with the thrust technique. So
Yeah.
I typically go without towel.
Yeah.
And
that's
the
fair.
other thing that I have the ability to do is I can wrap pretty much around everyone.
Lucky you.
Lucky me. But I've seen you use almost an augmented position where you grasp the bottom elbow
Yeah.
rather than the top elbow.
Yeah.
I think for me, getting into that position, I just feel too big
Yeah.
and I don't know where to thrust.
Yeah.
So
yeah.
for me, I almost aim for the opposite. I need to find a way to disperse my length.
Yeah. Interesting.
And I think if you watched us do it side by side, you'd appreciate that.
Yeah. And so just as a reminder for the learners, this is just one method of doing this technique, but the more you practice on different body types and get feedback, it becomes clear that everyone has to use a slightly different, you know, method to really accomplish that goal. This next technique, I use a ton. This is the seated CT junction distraction thrust technique. Let's go ahead and watch that video and then we can kind of talk about different patients that we would use this for. Now for the seated CT junction distraction technique, the patient isn't sitting and their hands are like this, protecting their mid-cervical spine. And so what I like to do when I'm doing a technique here, I'm really trying to target lower cervical, upper thoracic, so C7, T1, T2. I like to have a towel roll to use for the technique to really be a barrier between myself and the patient, but also just to make it a little bit more targeted in that particular region. So I'm gonna place the towel roll here, and then I'm actually gonna come and interlace my own fingers, or my hands rather, on top of hers. Another thing to keep in mind is the more you can create some adduction of her trunk, the more effective the technique can be. So I'm gonna have you just look up a little bit, Kylie, and bring your elbows in, but relax your upper body. Good, and so my hands are behind her neck. First, I'm gonna test the movement. Are you okay with that right there? Good, and I'm gonna just give you a little push straight up towards the ceiling. So let me have you take a deep breath in, long breath out. Good. And so the force vector is posterior and superior towards the ceiling.
As the name demonstrates, this is a cervico-thoracic aimed intervention, and I use it for exactly those patient populations. Folks who have thoracic impairments or thoracic symptoms, and folks who have cervical symptoms and cervical impairments.
Mm-hmm.
You know, I've seen you use this in folks with shoulder pain, but I've seen you use some interesting ways to get the affected shoulder out of the way. Could you describe that?
Yeah, that's a good point, which wasn't demonstrated here in the video. But a lot of times what we'll do, you know, you're coming behind the patient's neck and their hands are interlaced and yours are going on top of it. But instead of having their hand here interlaced, you're actually just going to leave that hand completely out of it and let that arm hang. And then instead, I'm coming in and I'm interlacing my hand with theirs. You know, so I warn them where I'm coming in, but truly that involved shoulder, if it were the right shoulder, is completely passive. And I'm threaded underneath here. But it allows us to still use that technique because I think it's just really effective not just for, neck pain, but locally. Sometimes people complain of localized cervical thoracic pain, especially our office workers and people that are in static positions for long periods of time.
Yeah, and like you mentioned, just the patient population that I see here, there are some folks who would never make it into a cervical thoracic inclusion study.
Yes.
So that patient population, I think you've got to be creative on how you apply the technique in a safe way, abiding by the contraindications and patient preferences, but still delivering a technique that can be really helpful.
Yeah, I agree with that. And I think, as Bryce mentioned before, with a different technique, there's no reason you can't come in here and create some distraction locally, because sometimes that in itself, especially for someone that maybe has higher fear avoidance, doesn't really want to be manipulated, you can actually still, I believe, get some work done by introducing to them and making them more familiar with some of those positions where they can get relief. This next technique is seated physiological rotation with non-thrust, unilateral, or central PA. The reason why I like this is it's in the answer's in the name. It's physiological. And so sometimes we'll just take a functional movement, thoracic rotation, lumbar movement, and create the mobilization there. It's a little bit easier to, I think, picture when we're talking about people with shoulder pain and you take the shoulder into full flexion and you do a physiological mobilization there. But we can do this in the neck. We can do it in the thoracic region. So I just want to show you what this looks like before we kind of proceed. So this is a seated thoracic physiological technique. And what I mean by physiological is I'm really doing the manual therapy intervention along with the physiological movement that's occurring. And in this instance, we're using rotation. And so the patient's arms are crossed over one another. And I'm just going to come through those crossed arms and put my hand over here in order to get a little bit more stability through the thorax. I can make this a central or a unilateral technique. So to make it a central technique, I'm going to palpate the spinous process. I'm going to come just lateral to it, and I'm really just kind of mobilizing using my hand along that spinous process as I'm combining some rotation with the technique. If I want it to be a more unilateral technique, then I can move about 2 finger widths lateral, and I can do a little bit of a pisiform lock on that region, and then I can really just kind of drive the movement through my hand, but also keeping that rotational component as I go towards that end range with the patient.